Alright, future nurses, this is the moment everything changes. You are not here just to study, you are here to train like a real nurse. This is your final push before walking into that NCLEX exam room with confidence, clarity, and clinical judgment. Now let's get one thing straight right from the start. The NCLEX is not a test of memory. It is a test of safe nursing, smart prioritization, and real-time decision-making. Every question you face is not just testing facts, it is testing how you think when the pressure is on. Can you recognize what matters most? Can you act quickly and protect your patient's life? That is what this exam is truly about. So let me walk you through exactly what we are going to cover in this session. We will begin with the most high-yield topics you are guaranteed to see on the exam. We will cover prioritization and delegation, how to decide who to see first, what tasks can be safely delegated, and how to prevent harm. Then we will go into safety and infection control, including isolation precautions, personal protective equipment, needle safety, and fall prevention. After that, we will tackle pharmacology, breaking down high-risk drug categories, side effects, and safe administration principles. Medication calculations will follow, because you absolutely must know how to calculate dosages, drip rates, and safe administration limits. This is not the place to guess. From there, we will explore additional frequently tested areas, how to apply restraints safely, proper crutch walking techniques, and patient education, lab values, and how to immediately spot which ones are critical, arterial blood gas interpretation simplified step by step, and maternity and newborn care, especially postpartum hemorrhage, preeclampsia, and Apgar scoring. We will also review common medical surgical conditions like stroke, heart failure, and diabetes. And finally, we will address mental health strategies, including therapeutic communication, one of the biggest traps on the NCLEX. By the end of this session, you will feel more prepared, more focused, and ready to walk into the exam room with clarity and confidence. We will start with prioritization, and your go-to framework is the ABCs: airway, breathing, and circulation. Every time the NCLEX asks which patient should the nurse see first, you immediately run through the ABCs. For airway, remember this: if a patient cannot breathe, nothing else matters. For example, if a child has stridor, that is an airway emergency and your top priority. Breathing comes next. If a patient has an oxygen saturation of 82%, that is hypoxia, and they need immediate intervention, then comes circulation. If a patient has a blood pressure of 80/40 and is showing new confusion, that is a red flag for organ hypoperfusion or shock. In that case, you go to them right away. So remember, airway is always first, followed by breathing and oxygenation, then circulation. Now here is a quick prioritization rule that helps you avoid common NCLEX traps. Physical needs come before psychosocial ones unless there is an immediate risk to safety. For example, if patient A is actively bleeding and patient B is having a panic attack, you prioritize patient A. Bleeding is a physical emergency and could lead to hypovolemic shock, which is life-threatening. Let us now talk about stable versus unstable patients. The rule is simple. Unstable patients must be seen first. This includes patients with sudden confusion, new chest pain, anyone in the first 24 hours after surgery, or those showing signs of stroke, sepsis, or shock. Also, vital sign changes such as low oxygen saturation, bradycardia, or hypertension indicate instability. On the other hand, stable patients can safely wait. These are patients with chronic conditions like controlled chronic obstructive pulmonary disease or hypertension, those with controlled pain, and patients who are ready for discharge. For example, if patient A has new confusion and a blood pressure of 80/40 and patient B needs their scheduled insulin, you see patient A first. They are unstable with neurologic and circulatory changes. Now let us move into delegation. The NCLEX loves to test your understanding of who can safely perform which tasks. Here is your golden rule: never delegate what you can evaluate, assess, or teach. Evaluation, assessment, and teaching require critical thinking and are the responsibility of the registered nurse. Registered nurses are responsible for initial assessments, full head-to-toe evaluations, discharge teaching, and patient education, administering intravenous push medications and blood transfusions, caring for unstable patients, and creating nursing diagnoses and care plans. Licensed practical nurses work under the supervision of the registered nurse and care for stable patients with predictable outcomes. They can administer oral, subcutaneous, and intramuscular medications, reinforce education that was previously given by the registered nurse, perform wound care, change dressings, and insert catheters. However, licensed practical nurses do not give intravenous push medications or initiate patient teaching. Unlicensed assistive personnel are responsible for assisting with basic care. They can help with activities of daily living such as bathing, feeding, toileting, ambulation, and repositioning. They can take vital signs but only for stable patients, and they can transport patients who are not critical. Here is a quick NCLEX-style question. Which task is appropriate to delegate to an unlicensed assistive personnel? If the answer choices include ambulate a stable post-operative patient or monitor for side effects after a blood transfusion, the correct answer is to ambulate the stable patient. Monitoring for side effects is a task that involves evaluation, which only a registered nurse should perform. Let us now briefly touch on discharge decisions. Another place where NCLEX can test prioritization. When hospital beds are full and you are asked who can safely be discharged, remember, you can discharge patients with chronic conditions that are stable, such as a chronic obstructive pulmonary disease patient going home on oxygen. You can also discharge post-operative patients who are recovering well with no complications. But you cannot discharge someone who has new or worsening symptoms, who has had surgery less than 24 hours ago, or who is showing signs of instability or complication. For example, if patient A has stable chronic obstructive pulmonary disease and patient B is 6 hours post-operative with new hypotension, you discharge patient A and keep patient B. To master prioritization and delegation, always keep safety first. Use the ABCs and Maslow's hierarchy of needs when in doubt. Do not make assumptions. Act only on what is given in the scenario. Registered nurses manage unstable patients and perform all tasks requiring critical thinking. Licensed practical nurses handle stable patients with routine care needs. Unlicensed assistive personnel assist with basic support and comfort care, but not assessment, monitoring, or teaching. So let us recap. You now know how to identify the most critical patient, how to safely delegate tasks, and how to make decisions that protect your license and, more importantly, your patient. This section is foundational to your success on the NCLEX. Take the time to review it thoroughly, practice applying it to clinical scenarios, and keep thinking critically. Now, if that was helpful, just wait for what's coming next. Our next topic builds on this foundation and will push your clinical thinking even further. Get ready, we're just getting warmed up. Let's take a quick moment before we begin. Are you confident about passing the NCLEX? If not, don't worry. The Complete NCLEX Review online course gives you 100 hours of animations, 500 hours of recorded lectures, 5,000 practice questions, 500 NGN-style cases, and 15 mock exams just like the real test. You'll also get an ebook and 1 year of full access. Enroll now and get 70% off only for a short time. Head to the link in the description and start your success journey. Alright team, you've been doing great. Now it's time to master a section that shows up on every NCLEX exam and becomes part of your everyday practice as a nurse: safety and infection control. Alright class, let us begin with a topic that appears on every single NCLEX exam: safety and infection control. I want you to understand that this is not just about memorizing procedures or checking off tasks. This is about preventing the spread of infection, protecting your patients, your healthcare team, and yourself. Whether you are taking the NCLEX or working on a hospital floor, this knowledge is essential and life-saving. We will start with personal protective equipment, which includes everything you wear to prevent direct exposure to infectious materials. But here is what many students miss. If you do not put on and take off personal protective equipment in the correct sequence, you may end up spreading contamination rather than preventing it. So let us begin with the correct sequence for donning or putting on personal protective equipment. The correct order is gown first, then mask, followed by goggles or face shield, and finally gloves. You can remember it with a phrase like gown up, mask on, goggles in place, gloves last. The gown protects your skin and clothing. The mask protects your airway from inhaling infectious droplets. Goggles or a face shield protect your eyes, and gloves protect your hands and complete the barrier. Before donning any personal protective equipment, you must perform hand hygiene thoroughly. If you are using a National Institute for Occupational Safety and Health approved N95 respirator, you must also perform a proper seal check before entering the room. Now let us move on to the removal or doffing of personal protective equipment. This is a critical step because improper removal is one of the most common ways healthcare workers get exposed to infections. The correct order is gloves first, followed by goggles or face shield, then the gown, and lastly the mask. Think of the phrase gloves off first, mask off last. Start by removing gloves using the glove-to-glove and skin-to-skin method, making sure to avoid contact with the outer contaminated surface. Next, remove goggles or your face shield by the strap without touching the front. Then untie the gown, roll it inward while keeping the contaminated side inside and dispose of it carefully. Finally, remove your mask, and if it is an N95 respirator, do this outside the patient's room. Finish by performing hand hygiene again. This step is mandatory every time. Now let us move into isolation precautions, a topic that the NCLEX loves to test. There are three main types: airborne, droplet, and contact precautions. Let us go over each one and learn which infections fall under which category and what type of protection is required. For airborne precautions, use the mnemonic "My chicken has tuberculosis" to remember the diseases: measles, chickenpox, which is also known as varicella, herpes zoster in its disseminated form, and tuberculosis. These infections are transmitted through tiny airborne particles that can remain suspended in the air. For these patients, use a National Institute for Occupational Safety and Health approved N95 respirator, place them in a private room with negative pressure airflow, and limit their transport. If the patient must leave the room, they should wear a surgical mask to prevent spreading infection to others. Next are droplet precautions. The mnemonic Spiderman can help you remember these infections: sepsis, scarlet fever, streptococcal pharyngitis, pertussis, pneumonia, influenza, diphtheria, epiglottitis, rubella, mumps, meningitis, and adenovirus. These infections spread through larger respiratory droplets. The staff must wear a surgical mask when within close proximity, ideally within 3 to 6 feet of the patient. A private room is recommended, and the patient should also wear a surgical mask when being transported outside the room. Now let us review contact precautions. Use the phrase Mr. WE to recall these conditions. Multi-drug resistant organisms like methicillin-resistant Staphylococcus aureus and vancomycin-resistant Enterococcus respiratory syncytial virus, skin infections such as scabies and herpes simplex virus, wound infections, enteric infections like Clostridioides difficile, and eye infections like conjunctivitis. These infections spread through direct or indirect contact with the patient or their environment. For contact precautions, you must wear gloves and a gown for any interaction with the patient or their environment. A private room is preferred, or cohorting with a patient with the same infection is allowed. For Clostridioides difficile, alcohol-based hand sanitizer is not effective. You must wash hands with soap and water to eliminate the spores. Let us go through a quick NCLEX-style recap. For airborne precautions, you need a National Institute for Occupational Safety and Health approved N95 respirator and a negative pressure room for patients with tuberculosis, measles, chickenpox, or herpes zoster. For droplet precautions such as influenza or bacterial meningitis, use a surgical mask and place the patient in a private room. For contact precautions like Clostridioides difficile or methicillin-resistant Staphylococcus aureus, use gown and gloves and wash hands with soap and water. To summarize the sequence again, the order for donning personal protective equipment is gown, mask, goggles or face shield, and gloves. The order for doffing is gloves, goggles or face shield, gown and mask. These steps must always be followed precisely. Now, let me wrap up with this important reminder. This is not just a topic for the NCLEX. This is what real nursing looks like. Every single day in clinical practice, you will make decisions that affect safety and infection control, and every NCLEX exam includes these questions. If you are confident in this area, you are collecting easy points and proving that you are ready to keep your patients and your team safe. So when in doubt, go back to the basics. Ask yourself, which mode of transmission am I dealing with? What personal protective equipment protects everyone involved? What is the safest action right now? And remember the golden rule: gloves come off first, the mask comes off last. That wraps up our safety and infection control session. You now know how to properly use personal protective equipment, match each disease to the right precaution, and answer these NCLEX questions with clinical confidence. Now let us keep this momentum going and continue with the next high-yield NCLEX topic. You are doing an excellent job. Keep going strong. Wait a moment before we continue. This could change your entire NCLEX prep. Our Complete NCLEX Review course includes 100 hours of animated lectures, 500 hours of deep dive teaching, 5,000 powerful practice questions, 500 NGN-style items, and 15 full-length exam simulations. You will also receive a full-access NCLEX ebook for 12 months. The course is now 70% off. But not for long. Tap the link in the description and get started right now. Alright class, let us shift gears and dive into one of the most high-yield pharmacology topics you will encounter on the NCLEX: toxic drug levels, antidotes, and black box warnings. This section is not just about memorization, it is about recognizing life-threatening signs, responding quickly in clinical emergencies, and selecting the safest response during the exam. These concepts show up in nearly every category, from medical, surgical, nursing to psychiatric, pediatric emergencies, and even prioritization scenarios. So let us break it down in a way that is clear, actionable, and memorable. We will begin with toxic drug levels. Many medications have what is called a narrow therapeutic window. That means the difference between a helpful dose and a harmful one is very small. These are the medications that require close monitoring through laboratory testing because even slight increases in the blood level can cause toxicity. Let us start with digoxin. This medication is used to treat heart failure and atrial fibrillation. Its therapeutic range is 0.5 to 2.0 nanograms per milliliter. When digoxin levels rise above this range, the patient may develop nausea, vomiting, slow heart rate, and changes in vision such as yellow-green halos or blurred vision. A helpful NCLEX clue is this: if your patient says, "Everything looks like Van Gogh's Starry Night," immediately think about digoxin toxicity. Next is lithium, a medication used to treat bipolar disorder. The therapeutic range is 0.6 to 1.2 milliequivalents per liter, and toxicity can begin at levels of 1.5 and above. Signs of lithium toxicity include tremors, confusion, nausea, vomiting, diarrhea, and excessive urination. Lithium is toxic to the kidneys, so you must monitor blood urea nitrogen, creatinine, and sodium. Also remember that dehydration can rapidly increase the risk of toxicity. Phenytoin is another medication to watch for. It is used to prevent seizures. The therapeutic range is 10 to 20 micrograms per milliliter. If levels go higher, the patient may experience loss of coordination, slurred speech, and tremors. A good memory tip is this: if your patient is stumbling and mumbling, check their phenytoin level. Now let us review theophylline. It is a bronchodilator, sometimes used for asthma or chronic obstructive pulmonary disease, although it is less common today. Its therapeutic range is 10 to 20 micrograms per milliliter. Toxic signs include seizures and dangerously fast or irregular heart rhythms. Even though it is not widely prescribed, theophylline is still tested on the NCLEX. Finally, we have acetaminophen, also known as paracetamol. The therapeutic range is up to 30 micrograms per milliliter. Toxicity can occur when levels exceed 150 to 200 micrograms per milliliter. The biggest danger is liver damage. Always monitor alanine transaminase and aspartate transaminase. If a patient overdoses on acetaminophen or combination medications like hydrocodone acetaminophen, you must suspect liver toxicity immediately. Here is a quick summary of what to look for with these drugs. Digoxin causes vision changes and a slow heart rate. Lithium leads to tremors, confusion, and dehydration. Phenytoin can result in balance issues and slurred speech. Theophylline can cause seizures and irregular heart rhythms. Acetaminophen can damage the liver and raise liver enzyme levels. Now let us move into antidotes, the life-saving interventions that you must know cold for the NCLEX. These are frequently tested in clinical judgment questions such as, which action should the nurse take first? For opioid overdose, the antidote is naloxone, also known as Narcan. For acetaminophen toxicity, you will give N-acetylcysteine. Magnesium sulfate toxicity is reversed with calcium gluconate. For heparin overdose, the antidote is protamine sulfate. For warfarin overdose, you must give vitamin K, also called phytonadione. In the case of digoxin toxicity, administer digoxin immune fab, commonly known as Digibind. If your patient has a dangerously high potassium level, give insulin with glucose, sodium polystyrene sulfonate, or sodium bicarbonate. For alcohol withdrawal, benzodiazepines such as lorazepam are used. In calcium channel blocker overdose, calcium gluconate is the go-to treatment. The NCLEX may describe a crashing patient and list multiple medications. If naloxone, N-acetylcysteine, or calcium gluconate are among the options, think quickly and choose the appropriate antidote based on the scenario. Now let us review black box warnings. These are the United States Food and Drug Administration's strongest safety alerts and are frequently tested on the NCLEX to see if you can spot high-risk situations. Beta blockers, which include medications like metoprolol and propranolol, all end in the letters LOL. Use the mnemonic A, B, C, D. A is for asthma. Beta blockers can cause bronchospasm. B is for bradycardia. C is for worsening of congestive heart failure. D is for diabetes, because beta blockers can mask signs of low blood sugar. If your patient has wheezing and asthma, never give a beta blocker. Next are angiotensin-converting enzyme inhibitors, like lisinopril. These can cause angioedema, which is a life-threatening swelling of the face, lips, or tongue. If a patient complains of their lips feeling swollen or tight, stop the medication immediately, notify the provider, and be ready for possible intubation. Now let us talk about antidepressants, including selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and tricyclic antidepressants. All of these carry a black box warning for increased risk of suicide, especially in young adults and teenagers. Do not dismiss comments like "I feel like giving up." This is a priority issue and needs immediate follow-up. Lastly, certain medications can cause prolongation of the QT interval on the electrocardiogram, increasing the risk of torsades de pointes, which is a life-threatening heart rhythm. This includes some antipsychotics, antiarrhythmic drugs, and even antibiotics like azithromycin. If your patient is taking multiple medications that prolong the QT interval, monitor their electrocardiogram closely. Here is your final NCLEX recap. Know the toxic drug levels for digoxin, lithium, phenytoin, theophylline, and acetaminophen. Memorize your antidotes: naloxone, N-acetylcysteine, vitamin K, calcium gluconate, digibine, protamine sulfate, and others. Understand which drugs carry black box warnings and what symptoms should trigger you to stop the drug and call for help. And remember, if you ever suspect drug toxicity, your first action is to stop the drug, check the laboratory values, administer the appropriate antidote if available, and notify the healthcare provider. That concludes your crash course on toxic drug levels, antidotes, and black box warnings. You have just mastered one of the most frequently tested areas of NCLEX pharmacology. And remember, the key is not just memorizing, it is understanding the why behind every safety measure you take. Let us keep the momentum going. You are doing great, and your NCLEX success is just around the corner. Let us continue building that nursing brain. One quick heads up before we begin. If you're serious about passing the NCLEX, the Complete NCLEX Review online course has every resource you need. 100 animated hours, 500 in-depth lectures, 5,000 questions, 500 NGN items, and 15 simulated exams. You will also get a 1-year NCLEX ebook to study anytime. Right now, get 70% off. Limited time offer. Click the link below and take your first step toward passing. Let's talk about something that might feel intimidating at first, but I promise, by the end of this lesson, it's going to feel like second nature. Alright everyone, take a deep breath because we are about to walk through something that makes a lot of students nervous: medication calculations. Now, I understand. For many of you, mathematics may not be your favorite subject. Seeing numbers during NCLEX review might make your heart skip a beat. But here is the good news. This is one of the easiest areas to earn guaranteed points on the NCLEX if you know the formula, and I promise you, today I'm going to keep it simple, stress-free, and maybe even a little bit fun. Let us begin with the core medication formula. This one is absolutely essential for the exam and for clinical practice. The formula is desired dose divided by dose on hand multiplied by the quantity it comes in equals the amount you give to the patient. In simple terms, D divided by H times Q equals X. D stands for the desired dose, that is what the healthcare provider has ordered. H stands for the dose on hand, what is available in the medication drawer or vial. Q stands for the quantity, which could be 1 tablet, 5 milliliters, or whatever unit the drug is supplied in. X is what you will give to the patient. Let us walk through a couple of examples to bring it to life. In the first example, the order is for 50 milligrams of a medication. What you have available are 25 milligram tablets. Plugging it into our formula, 50 divided by 25 times 1 tablet equals 2 tablets. So, you would administer 2 tablets. In the second example, the provider orders 600 milligrams of amoxicillin. The available supply is 200 milligrams in 5 milliliters of liquid. Plug it in. 600 divided by 200 times 5 equals 15. You would draw up and administer 15 milliliters of the medication. A useful clinical tip here is About safety state, always label your units. Write out milligrams, milliliters, or tablets. Forgetting to label can cost you points on the NCLEX, and in real life, it could harm a patient. Now, let us move into intravenous fluid flow rates when using an infusion pump. The formula is simple. Total volume in milliliters divided by time in hours equals the rate in milliliters per hour. For example, if the order is to infuse 1000 milliliters of normal saline over 8 hours, you divide 1000 by 8. The result is 125, so you would set the infusion pump to 125 milliliters per hour. Here are a few NCLEX tips specifically for intravenous fluid rate questions. Unless the question tells you otherwise, round intravenous rates to the nearest whole number. Always include your units. Milliliters per hour is very different from milliliters per minute. If your answer feels too big or too small, pause and double check. That gut check can save your patient and your score. One key strategy that can help you avoid common mistakes is to label every value before you start plugging numbers into the formula. Write out D equals what the provider ordered, H equals what you have, and Q equals the quantity it is supplied in. Then calculate. This reduces the chance of mixing up numbers or units, which is one of the most frequent NCLEX mistakes. As we wrap up this section, here are a few final reminders. Do not rush your calculations. In medication math, slow is safe. Use your scratch paper and write out each formula step by step. Keep a close eye on your units. Micrograms is not the same as milligrams, and missing a conversion could be dangerous. And if your answer seems off, pause, recheck, and calculate again before submitting. So what did you just accomplish? You mastered basic dosage formulas, tablet and liquid medication calculations, and intravenous infusion pump flow rate calculations. And most importantly, you practiced thinking clearly and safely under pressure, which is exactly what the NCLEX is designed to test. You crushed this one, and the best part, we are not done yet. Coming up next, we will cover manual intravenous drip rates and weight-based dosing. That way, you will be fully covered from the syringe to the infusion pump. Let us keep the momentum going. You are doing an amazing job. Before we break down this question, here's a game changer. The Complete NCLEX Review online course gives you 100 hours of animation, 500 hours of recorded content, 5,000 essential questions, 500 NGN-style clinical cases, and 15 full mock exams. Plus, you'll get a detailed NCLEX ebook with 1 year access. Get in now, 70% off, but not for long. The link's in the description. Thousands of future nurses are already ahead. Don't get left behind. Let's keep the energy high and your confidence growing, because what we're covering next will absolutely show up on your NCLEX and could even show up on your first day as a nurse. Alright class, you are doing great so far, and now it is time to build on what you have already learned. We have covered basic medication dosage formulas and intravenous infusion pump calculations, and now we are moving into two more high-yield medication math skills that appear over and over again on the NCLEX: manual intravenous drip rates and weight-based dosing. These are essential, especially in pediatric and emergency care settings. Let us start with manual intravenous drip rate calculations, also known as gravity flow. In some clinical environments, particularly in rural areas or emergency situations, you might not have access to a programmed intravenous infusion pump. In those cases, you need to rely on gravity and calculate how many drops per minute to deliver. The formula to remember is this: total volume multiplied by drop factor divided by time in minutes equals drops per minute. Let us go through it step by step. If you are ordered to infuse 1000 milliliters of normal saline over 8 hours, and the tubing has a drop factor of 15 drops per milliliter, you first need to convert the hours to minutes. 8 hours multiplied by 60 equals 480 minutes. Now plug the values into the formula. 1000 milliliters times 15 drops per milliliter equals 15,000. Divide that by 480 minutes and you get 31.25. Since you cannot give partial drops, you round to the nearest whole number, which is 31 drops per minute. Now let us move into weight-based dosing, a critical concept when caring for pediatric patients, those receiving chemotherapy, or individuals on high-risk medications like heparin or vasopressors. The formula for this is very straightforward. Weight in kilograms multiplied by the ordered dose in milligrams per kilogram equals the total dose in milligrams. But first, always make sure the weight is in kilograms, not pounds. Remember that 1 kilogram equals 2.2 pounds. For example, if a provider orders 15 milligrams of acetaminophen per kilogram for a child who weighs 44 pounds, you first convert the weight. Divide 44 by 2.2 and you get 20 kilograms. Then multiply 20 kilograms by 15 milligrams per kilogram, and the total dose is 300 milligrams. If this medication is given in liquid form, as with many pediatric patients, you would then look at the medication label to convert that dose to milliliters based on the concentration. Always verify the medication strength and route before preparing your dose. Let me now share a few essential NCLEX safety tips for all medication math questions. First, always label your units, whether it is milligrams, milliliters, micrograms, or drops per minute. Unit errors are one of the most common and dangerous mistakes on the exam and in clinical settings. Second, never round your answer until the final step of the calculation. Keep all decimal places intact as you calculate, and only round when your final answer is ready, based on the instructions in the question. Third, know what type of rounding is expected. For intravenous infusion pump questions, round to the nearest whole milliliter per hour unless told otherwise. For drip rate questions using gravity tubing, round to the nearest whole drop per minute, since you cannot administer partial drops. For weight-based dosing, only round if the question explicitly instructs you to. Let me leave you with this. You do not need to be a math genius to succeed on the NCLEX. What you do need is a clear understanding of the formulas, the ability to plug in numbers carefully, and the mindset of a safe and detail-oriented nurse. And the best part? Once you get used to these formulas, these questions become some of the fastest and most confident points you can earn on the exam. So do not fear medication math. Practice it, own it, and be ready to apply it on test day. You are picking up serious momentum now, and we're not done yet. Coming up next, we will continue building your NCLEX power skills. You are not just reviewing content, you are training to think and act like a real nurse. Let us keep the momentum going. You are doing amazing. Hold on just a sec, let's talk strategy. The Complete NCLEX Review online course is your fast-track prep kit. 100 animated hours, 500 hours of lectures, 5,000 questions, 500 NGN-style cases, and 15 exam simulations. All this plus a year-long NCLEX EBOOK. Act fast, it's now 70% off for a limited time. Visit our site using the link in the description and start today. Let us jump into a topic that might catch some nursing students off guard with how often it shows up on the NCLEX. Restraints and crutches, two subjects deeply tied to patient safety, ethical decision-making, and proper nursing procedure. Although these may seem like basic skills, they are highly testable because they demonstrate your understanding of what it means to be a safe nurse. So let us break it down. When it comes to restraints, the golden rule is that they are always a last resort. Restraints should never be used out of convenience, frustration, or for punitive reasons. They are only appropriate when the patient poses an immediate threat to themselves or others, when less restrictive methods have failed, and when there is a current provider's order in place. In emergencies, restraints can be applied temporarily, but the provider must be notified right away and all actions documented thoroughly. Appropriate restraint use includes scenarios like a physically aggressive patient attacking staff, a confused post-stroke patient repeatedly removing a nasogastric tube, or a delirious client attempting to pull out central lines. Inappropriate use includes restraining a wandering dementia patient who is not actively at risk, someone simply yelling or using restraints just in case when staffing is limited. Before reaching for restraints, the NCLEX wants to see that you have tried less restrictive measures like reorienting the patient, moving them near the nurse's station, engaging bed alarms, providing distraction through family support or media, and using low beds or floor mats. For instance, if a confused patient is pulling at their intravenous line, a protective sleeve is a safer and more appropriate first step than restraints. Now, when restraints are necessary, tie them to the bed frame, not the side rails, using a quick release knot that allows for rapid removal in emergencies. Assess the patient every 15 to 30 minutes and remove restraints at least every 2 hours to check circulation, perform range of motion exercises, assist with toileting, and ensure hydration. Improper use of restraints may legally be considered abuse, and complete documentation is essential for protecting both the patient and yourself. Now let us shift to crutches, another fundamental yet highly testable NCLEX topic under fall prevention. First, ensure that the crutches fit properly. There should be 2 to 3 finger widths of space between the top of the crutch and the armpit, elbows bent at 30 degrees, and weight supported by the hands, not the underarms, to prevent crutch palsy, a nerve injury that causes arm numbness or weakness. If a patient complains of tingling, suspect poor fit. There are 4 common crutch gait patterns. The 2-point gait is used when partial weight bearing is allowed on both legs. The left crutch and right foot move together. then the right crutch and left foot. The 3-point gait is for patients who are non-weight bearing on one leg. Both crutches move forward, followed by the unaffected leg. The 4-point gait is for patients who can bear full weight but need maximum stability. Move one crutch, the opposite foot, then the other crutch, followed by the remaining foot. The swing-through gait is used by patients with paralysis or very strong upper body strength. Both crutches move forward and both legs swing through. On stairs, remember the phrase, up with the good, down with the bad. Going upstairs, strong leg first, then crutches, then weaker leg. Going downstairs, crutches first, then the weaker leg, then the strong leg. For your NCLEX summary, restraints require prior attempts at less restrictive measures, a provider's order, frequent assessment, safe tying, and scheduled removal. For crutches, ensure proper fitting, instruct on the correct gait for the patient's weight-bearing ability, and reinforce stair safety. These concepts may seem routine, but on the NCLEX and in practice, they are vital. They reflect your ability to deliver safe, ethical, and evidence-based care. You did a great job mastering this critical topic, so let us take that momentum forward and step confidently into our next high-yield NCLEX segment. Right before we get into the question, let me ask you this. Is your NCLEX prep complete? If not, the Complete NCLEX Review course gives you 100 hours of animations, 500 hours of lecture content, 5,000 high-yield questions, 500 NGN cases, and 15 mock exams, all with a year-long ebook. Save 70% today, but the deal won't last. Click the description link to enroll and start strong. Let us switch into critical thinking mode because this next NCLEX section is not just about memorization. It is about demonstrating the kind of clinical judgment that sets you apart as a safe, sharp, and ready nurse. We are diving into laboratory values and arterial blood gas interpretation. And trust me, this is not just a numbers game. The NCLEX will not simply ask, what is the normal range of potassium? Instead, it will hand you a scenario, throw in some labs, and then ask, what system is failing? Or, what should the nurse do next? Your job is to look at those numbers and make decisions that protect your patient's life. And that starts with truly understanding what each value means. Let us begin with the most testable electrolytes. Sodium, with a normal range of 135 to 145 milliequivalents per liter, affects the brain. Low sodium equals confusion, seizures, maybe even coma. High sodium means dehydration signs like thirst and restlessness. Now potassium is all about the heart. Its normal range is 3.5 to 5.0. Hyperkalemia can lead to tall peaked T waves and deadly arrhythmias, while hypokalemia gives you flattened T waves, muscle cramps, and more dysrhythmias. Calcium, which should stay between 8.5 and 10.5 milligrams per deciliter, influences muscle and nerve activity. Low calcium gives you tetany and those classic positive Javostex and Trousseau's signs. High calcium, think weakness and sluggish reflexes. Then we have magnesium, 1.5 to 2.5, which also affects reflexes and cardiac rhythm. Low magnesium, hyperreflexia and a serious risk for torsades de pointes. High magnesium, expect bradycardia, decreased reflexes, and potential respiratory depression. Phosphorus runs 2.5 to 4.5 and typically rises in kidney failure. When phosphorus goes up, calcium goes down and vice versa. Chloride supports acid-base balance and mirrors sodium. Not usually tested on its own, but always connected to the big picture. Quick summary: sodium equals brain, potassium equals heart, calcium and magnesium equal reflexes, phosphorus equals kidneys and bones. Now let us tackle arterial blood gases. And this is where you really start thinking like a nurse. Here are your ranges: pH from 7.35 to 7.45, carbon dioxide from 35 to 45 millimeters of mercury, and bicarbonate from 22 to 26. Use the ROM method, respiratory opposite, metabolic equal. If pH and carbon dioxide move in opposite directions, it is respiratory. If pH and bicarbonate move in the same direction, it is metabolic. Let us apply that. If pH is low and carbon dioxide is high, it is respiratory acidosis. Think opioid overdose, chronic obstructive pulmonary disease, or hypoventilation. If pH is high and carbon dioxide is low, it is respiratory alkalosis, hyperventilation, anxiety, or early sepsis. For metabolic acidosis, both pH and bicarbonate are low. Causes include diabetic ketoacidosis, renal failure, or diarrhea. For metabolic alkalosis, both are high. Think vomiting or nasogastric suctioning. Here is how to nail it on the NCLEX. Diabetic ketoacidosis equals metabolic acidosis. Vomiting equals metabolic alkalosis. Panic attack equals respiratory alkalosis. And opioid overdose equals respiratory acidosis. Always ask, is this a lung or kidney issue? Is the body compensating? What do I do first to protect the patient? Now let us wrap it all up with your NCLEX power moves. First, connect each lab value to a symptom and a system. Second, apply the ROME method to break down arterial blood gases. Third, figure out which organ system is causing the problem, lungs or kidneys. Fourth, do not panic over one out of range number. Look at the full clinical picture. And above all, choose the safest next step. This section proves that you are not just studying, you are learning how to think and act like a nurse. You are developing the clinical instincts that keep patients alive. That was a major win. And we are not done yet. Stay logged in because up next we are diving into another high-yield NCLEX topic that will sharpen your judgment and boost your score even higher. Let us keep leveling up. Are you completely prepared for the NCLEX? If there's even a bit of hesitation, our Complete NCLEX Review online course has your back. You'll get access to 100 hours of animated content, 500 hours of in-depth lectures, 5,000 high-yield questions, 500 NGN-style case questions, and 15 mock exams designed to feel like the real thing. You'll also receive a comprehensive NCLEX ebook, all valid for 1 full year. Right now, you can grab it at 70% off for a limited time. Thousands of students are already on the path to success, and you can be too. Click the link in the description and get started. Now that you have leveled up your understanding of laboratory values and critical decision making, it is time to dive deeper into a topic that blends diagnostics, pharmacology, and safety, and is practically guaranteed to appear on the NCLEX. We are talking about complete blood count and coagulation studies, a high-yield subject that plays a vital role in scenarios related to infection risk, bleeding danger, and surgical readiness. The moment you ask yourself, should I give this anticoagulant, or is this patient too unstable for a procedure? The answer lies in this laboratory section. Let us begin with the complete blood count, a group of values that give insight into immune function, oxygen carrying capacity, and clotting ability. White blood cells with a normal range of 4,000 to 11,000 per microliter are the frontline defenders. A high count can indicate infection, inflammation, or leukemia, while a low count, called leukopenia, puts the patient at serious risk for infection, especially in those undergoing chemotherapy or living with human immunodeficiency virus. If the patient presents with a fever and a white blood cell count below 4,000, that is a neutropenic emergency. Initiate neutropenic precautions and contact the healthcare provider immediately. Next are red blood cells ranging from 4.2 to 6.1 million per microliter. These cells carry oxygen, and when their levels are low due to anemia, blood loss, or nutritional deficits, symptoms include fatigue, pallor, dizziness, and shortness of breath. If an anemic patient also reports chest pain, it becomes a high priority situation due to reduced oxygen supply to the heart. High red blood cell counts, or polycythemia, increase clotting risk and are often linked to chronic hypoxia or bone marrow disorders. Hemoglobin and hematocrit, with normal values of 12 to 17 grams per deciliter and 37 to 52% respectively, also reflect oxygen carrying capacity and fluid balance. Low hemoglobin and hematocrit may signal blood loss or anemia, while elevated values may point to dehydration or polycythemia. If your patient has dizziness, pallor, and tachycardia, check those hemoglobin and hematocrit levels right away. The final complete blood count component is platelets, normal range 150,000 to 400,000 per microliter, and they are critical for clot formation. Thrombocytopenia, or a low platelet count, raises the risk for spontaneous bleeding, especially when levels dip below 100,000. If platelets fall under 50,000, injections, invasive procedures, and surgery should be avoided to prevent severe hemorrhage. Now let us move into coagulation studies, which are essential in managing anticoagulation therapy and pre-surgical decisions. Prothrombin time, or prothrombin time, normally falls between 11 to 14 seconds. When a patient is on warfarin, the therapeutic goal is for prothrombin time to be 1.5 to 2 times higher, around 16 to 28 seconds. The International Normalized Ratio, or International Normalized Ratio, standardizes prothrombin time. Normally, it is between 0.8 to 1.2. For warfarin therapy, the goal is between 2.0 and 3.0. If the patient has a mechanical heart valve, it goes up to 2.5 to 3.5. A high international normalized ratio means high bleeding risk, and if it exceeds 3, assess for bleeding signs and consider holding the medication. A low international normalized ratio increases the risk for clot formation. Activated partial thromboplastin time or activated partial thromboplastin time typically ranges from 30 to 40 seconds. For patients receiving heparin, the target is 60 to 80 seconds. If activated partial thromboplastin time exceeds 80, hold the heparin and notify the provider. These values are your green lights and red flags when managing anticoagulation. Here is a quick safety cheat sheet. If the platelets are low, avoid anticoagulants, injections, and anything invasive. If the international normalized ratio or activated partial thromboplastin time is too high, hold medications and assess for bleeding. And yes, memorize your reversal agents, vitamin K for warfarin, protamine sulfate for heparin. NCLEX loves to combine laboratory values with action-based questions. So do not just know the number, know what to do about it. When you can look at a laboratory result and ask yourself, is this patient at risk? And confidently take the next step to protect them, that is clinical judgment in action. And that is what the NCLEX is truly testing. You are not just reading results, you are translating them into life-saving decisions. You are doing an incredible job, and you have just mastered another major concept on your journey to becoming a safe and competent nurse. Stick with me. The next high-yield NCLEX checkpoint is just ahead, and we are not slowing down. Let's take a quick moment before we begin. Are you confident about passing the NCLEX? If not, don't worry. The Complete NCLEX Review online course gives you 100 hours of animations, 500 hours of recorded lectures, 5,000 practice questions, 500 NCLEX-style cases, and 15 mock exams just like the real test. You will also get an ebook and 1 year of full access. Enroll now and get 70% off, only for a short time. Head to the link in the description and start your success journey. You have been sharpening your clinical judgment, and now it is time to bring that same energy into one of the highest yield categories on the NCLEX, maternity nursing. In this crucial segment, we are diving into fetal heart rate interpretation, the 4 stages of labor, postpartum hemorrhage, and fundal assessments, core concepts that not only dominate NCLEX exams but also define safe nursing care in labor and delivery. To begin, let us break down fetal heart rate monitoring using the NCLEX favorite mnemonic wheel CHOP. Variable decelerations equal cord compression, early decelerations equal head compression, accelerations equal oxygenation, which is a reassuring sign, and late decelerations equal placental insufficiency, which is a red flag requiring immediate action. For variable decelerations, reposition the mother, left side, right side, or hands and knees to relieve cord pressure. Early decelerations are benign and just require monitoring. Accelerations are healthy, indicating fetal well-being, but late decelerations demand urgent intervention. Stop the oxytocin infusion, turn the mother to her left side, give oxygen, start intravenous fluids, and notify the healthcare provider. A great NCLEX tip to remember is that early is expected, variable means move, and late is lethal. Moving into the stages of labor, the first stage includes cervical dilation from 0 to 10 centimeters, broken into 3 phases. The latent phase, where contractions are mild and the mother remains relaxed. The active phase, where contractions intensify and pain management becomes a priority. And the transition phase, where dilation reaches 8 to 10 centimeters and symptoms like shakiness and irritability peak. If pushing begins before full dilation, help the mother breathe through contractions to avoid cervical trauma. Contractions longer than 90 seconds or less than 2 minutes apart indicate uterine tachysystole, a serious complication requiring you to stop oxytocin, start intravenous fluids, and notify the provider. The second stage begins with full dilation and pushing. Watch for crowning. If shoulder dystocia occurs, apply the McRoberts maneuver and suprapubic pressure, never fundal pressure. Prolonged second stage without descent may call for assisted delivery. The third stage is delivery of the placenta, which should occur within 30 minutes. If delayed or accompanied by bleeding, perform fundal massage, give oxytocin, and monitor for hemorrhage. The fourth stage is the critical postpartum recovery period, the first 2 hours, where hemorrhage risk is highest. Assess fundal tone, lochia, and vital signs frequently. If the fundus is boggy, massage it immediately. A patient soaking more than 1 pad per hour must be evaluated for hemorrhage. Postpartum hemorrhage is defined as blood loss over 500 milliliters after vaginal birth or over 1000 milliliters after cesarean section. Interventions include fundal massage, checking for bladder distension, administering medications like oxytocin, methylargonovine, or carboprost, and watching for signs of hypovolemic shock such as low blood pressure, rapid heart rate, dizziness, and clammy skin. High-risk patients include those with multiple births, macrosomia, fast or prolonged labor, or uterine atony. If the uterus is not firm after massage, continue massaging and monitor closely. Fundal assessments are another NCLEX staple. The fundus should be firm and at the level of the umbilicus immediately after birth and descend 1 centimeter daily, becoming non-palpable by day 10 to 14. A fundus that is high or shifted to the right may indicate bladder distension. Have the patient void and reassess. Wrapping this up with a quick NCLEX maternity safety review. Use veal chop for fetal heart rates. Act fast on uterine tachysystole. Massage a boggy uterus. Monitor for postpartum hemorrhage and check fundal position daily. These are not just test answers. They are real-world nursing actions that keep mothers and newborns safe. You have just reviewed some of the most essential high-scoring material in maternity nursing. But more importantly, you have practiced the kind of critical thinking that saves lives. So stay sharp, stay confident, and let us carry this momentum straight into the next life-saving NCLEX topic. Hold up. Are you feeling confident about the NCLEX? If not, you will want to check out the Complete NCLEX Review online course. It's packed with 100 hours of animated videos, 500 hours of deep content, 5,000 practice questions, 500 NGN-style cases, and 15 full mock exams. There's also a full NCLEX ebook included with a 1-year access window, and right now, it's available for 70% off, but only for a short time. Click the link in the description and join the thousands of students who've already passed. Let us shift our attention to one of the most high-yield, exam-friendly, and clinically relevant topics in medical surgical nursing: heart failure. If you have ever felt overwhelmed by this subject, do not worry. Once we break it down together, you will see just how approachable it really is. A simple trick that helps distinguish the two major types is this. L stands for lungs and R stands for the rest of the body. That one-letter association will help you quickly and confidently identify whether the patient is experiencing left-sided or right-sided heart failure on any NCLEX question. In left-sided heart failure, the left ventricle becomes too weak to pump blood forward into systemic circulation, so blood backs up into the lungs instead. This causes hallmark respiratory symptoms such as shortness of breath, orthopnea, and crackles upon lung auscultation. One major red flag is paroxysmal nocturnal dyspnea, waking up gasping for air. And if you ever see pink frothy sputum mentioned in a question, that is your cue to immediately suspect acute pulmonary edema, a high priority emergency. Now in contrast, right-sided heart failure occurs when the right ventricle cannot effectively push blood into the lungs, so it backs up into the systemic venous system. This presents as peripheral edema, jugular vein distension, fluid accumulation in the abdomen known as ascites, and even hepatomegaly. One of the most telltale NCLEX combinations is seeing jugular vein distension, lower extremity swelling, and unexplained weight gain, all pointing clearly toward right-sided failure. When it comes to treatment, two major medication classes dominate NCLEX questions. First are diuretics like furosemide, which are used to eliminate excess fluid from the lungs in left-sided failure or from the body in right-sided failure. Monitor for adverse effects like low potassium levels, dehydration, and orthostatic hypotension. The second key group is angiotensin-converting enzyme inhibitors. Examples include lisinopril and enalapril. These medications reduce afterload, allowing the heart to pump more efficiently. Side effects you must remember include a persistent dry cough, hyperkalemia, and angioedema, which can become a life-threatening airway emergency. To wrap this up with a quick NCLEX-focused summary, left-sided heart failure presents with pulmonary symptoms like crackles and dyspnea, and your goal is to clear fluid from the lungs. Right-sided heart failure presents with systemic symptoms like swelling, ascites, and weight gain, and your job is to reduce overall congestion. First-line medications are diuretics and angiotensin-converting enzyme inhibitors. And you must always monitor closely for changes in blood pressure and electrolyte levels. Here is the memory trick that simplifies it all. Left equals lungs and right equals the rest of the body. Know the signs, understand the underlying cause, and respond fast. And just like that, you have mastered heart failure in one clear, high-yield session. Let us keep this momentum alive and dive into the next critical NCLEX topic that could show up on your exam. You are building the knowledge and confidence to pass with flying colors. Let's take a quick moment before we begin. Are you confident about passing the NCLEX? If not, don't worry. The Complete NCLEX Review online course gives you 100 hours of animations, 500 hours of recorded lectures, 5,000 practice questions, 500 NGN-style cases, and 15 mock exams just like the real test. You'll also get an ebook and 1 year of full access. Enroll now and get 70% off. Only for a short time. Head to the link in the description and start your success journey. Before we dive into complex pharmacology or intricate case scenarios, let us first master one of the most urgent, life-threatening emergencies you will face on the NCLEX: stroke. This is a condition where every second counts because, as we say in clinical practice, time is brain. For every minute a stroke goes untreated, nearly 2 million neurons die, which means your ability to recognize symptoms and respond immediately could quite literally save a life. The NCLEX is not just evaluating your ability to identify a diagnosis, it is assessing whether you know how to act fast and prioritize care in the right sequence. One of the most reliable tools you will use to recognize stroke symptoms is the acronym FAST, which stands for face drooping, arm weakness, speech difficulty, and time to call emergency services. If you are presented with a scenario showing facial asymmetry, slurred or nonsensical speech, or weakness on one side of the body, your very first nursing action must be to activate a stroke alert and prepare for rapid intervention. Now, let us talk about the two major types of stroke, because the treatment depends entirely on which type you are dealing with. The first is ischemic stroke, which accounts for nearly 90% of all stroke cases. This type occurs when a blood clot or embolus blocks oxygen-rich blood from reaching brain tissue. The first-line treatment in this situation is tissue plasminogen activator, a powerful clot-busting medication often abbreviated as TPA, but it can only be used under strict conditions. It must be given within 3 to 4.5 hours from the onset of symptoms, and only after a computed tomography scan confirms there is no intracranial bleeding. In addition, the patient's blood pressure must be below 185/110 millimeters of mercury. You never administer tissue plasminogen activator until the stroke has been confirmed to be ischemic. Otherwise, you could worsen the condition. On the other hand, hemorrhagic stroke results from a ruptured blood vessel in the brain, which causes internal bleeding and increases intracranial pressure. In this situation, tissue plasminogen activator is absolutely contraindicated. Your role is to stop the bleeding, lower the patient's blood pressure slowly and safely, and prepare for possible surgical intervention such as clipping or coiling. Monitor closely for signs of increased intracranial pressure, including a sudden severe headache, projectile vomiting, altered consciousness, or unequal pupils, and under no circumstances should you administer anticoagulants such as aspirin, heparin, warfarin, or clopidogrel. So when you suspect stroke, your very first nursing priority is to prepare the patient for an immediate computed tomography scan of the head. This one scan determines everything. No medication should be administered until the type of stroke is identified. To wrap up, remember the FAST tool to catch early warning signs, activate the stroke alert immediately, and follow the right path depending on the computed tomography results. For ischemic stroke, tissue plasminogen activator is your window of opportunity if the timing and criteria are met. For hemorrhagic stroke, your focus shifts to controlling bleeding and intracranial pressure. And finally, the NCLEX is not just testing your memory. It is testing whether you can lead in a crisis, protect the brain, and prioritize safety within minutes. Now that you know how to respond to one of the most time-sensitive emergencies in nursing, let us keep the energy going and step into the next critical condition that every future nurse must be ready to handle. Before today's question, here's something you need to hear. Your NCLEX success could start right here. Our Complete NCLEX Review online course includes 100 hours of engaging animations, 500 hours of focused lectures, 5,000 high-yield questions, 500 NGN case items, and 15 CAT-style exams. You'll also receive a full NCLEX ebook, valid for 12 months, and for now, it's available at 70% off. Thousands have already made it. Now it's your turn. Visit the website link in the description. Let us now turn our focus to a condition that the NCLEX loves to test, one that requires fast thinking, clinical precision, and sharp decision-making. and that is diabetic emergencies, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome. These two life-threatening conditions may appear similar at first, but they differ significantly in causes, symptoms, laboratory findings, and treatment priorities. And understanding those differences is what will set you apart on exam day. Let us begin with diabetic ketoacidosis, a condition most commonly seen in individuals with type 1 diabetes, typically triggered by missed insulin doses, infection, or new diagnosis without treatment. The key laboratory findings in diabetic ketoacidosis include a blood glucose level ranging from 250 to over 500 milligrams per deciliter, positive ketones in the blood and urine, a low blood pH under 7.35 indicating metabolic acidosis, decreased bicarbonate levels, and variable potassium levels that may look high at first but drop rapidly once insulin is started. Clinically, you will see small respirations, which are deep and rapid as the body tries to blow off acid, fruity scented breath due to ketone buildup, abdominal pain, nausea, vomiting, and clear signs of dehydration such as dry mucous membranes, hypotension, and tachycardia. The immediate nursing priorities are to initiate intravenous fluid resuscitation, start regular insulin on a continuous intravenous infusion, and closely monitor and replace potassium as needed. A critical NCLEX safety alert to remember: if potassium is below 3.3 milliequivalents per liter, insulin must be held until potassium is corrected, because starting insulin at that point could trigger a fatal cardiac arrhythmia. Now compare that to hyperosmolar hyperglycemic syndrome, which is more often seen in individuals with type 2 diabetes, particularly older adults who are not taking in enough fluids. Unlike diabetic ketoacidosis, hyperosmolar hyperglycemic syndrome is not associated with ketones or acidosis. Laboratory values in hyperosmolar hyperglycemic syndrome typically show blood glucose levels over 600 milligrams per deciliter, often approaching 1000, no ketones, a normal blood pH, extremely high serum osmolality, and the same potassium drop once insulin is started. What sets hyperosmolar hyperglycemic syndrome apart clinically is the profound dehydration and neurological changes. Patients may present with confusion, altered mental status, or even coma. The treatment is similar in sequence to diabetic ketoacidosis. Start with intravenous fluids first to restore volume, followed by careful insulin administration, and monitor potassium closely, even though acidosis is not present. To simplify the comparison, diabetic ketoacidosis occurs in type 1 diabetes with moderate hyperglycemia, positive ketones, acidosis, and small respirations, while hyperosmolar hyperglycemic syndrome occurs in type 2 diabetes with extremely high blood glucose levels, no ketones, normal pH, and more severe neurological symptoms. In both conditions, initial management begins with intravenous fluids followed by insulin with constant attention to potassium levels throughout. For the NCLEX, here is your quick decision-making tip. If the patient has deep rapid breathing, fruity smelling breath, a low pH, and ketones, you are looking at diabetic ketoacidosis. If the patient is confused, severely dehydrated, has no ketones, and blood glucose is in the thousands, it is hyperosmolar hyperglycemic syndrome. The priorities in both emergencies are clear and consistent. Fluids come first, insulin comes second, and potassium monitoring must never be overlooked. This is exactly the kind of question that gives you the opportunity to demonstrate clinical judgment. And now you are more than ready to handle it. Keep up the momentum, because mastering these high-risk conditions puts you one step closer to passing the NCLEX with confidence. Let's pause for a second. Are you ready to take the NCLEX with confidence? If not, don't worry. The Complete NCLEX Review course has 100 animated hours, 500 recorded hours, 5,000 high-yield practice questions, 500 NGN cases, and 15 mock exams built to mirror the real test. You also get a 1-year ebook. Enroll now and get 70% off. Limited time offer. The link is right in the description. As we bring this high-yield review to a close, let us take one final moment to tie everything together and sharpen your mindset for the NCLEX exam. You have just covered some of the most frequently tested safety-critical nursing concepts, and now it is time to solidify your understanding with one last rapid-fire walkthrough, the kind of mental checklist you will carry with you right into the testing center. Beginning with heart failure, remember this golden rule. L stands for lungs and R stands for rest of the body. Left-sided heart failure presents with respiratory symptoms such as shortness of breath, orthopnea, lung crackles, and pink frothy sputum, a red flag for pulmonary edema. Right-sided heart failure causes systemic congestion like peripheral edema, jugular vein distension, and fluid buildup in the abdomen known as ascites. Next, when it comes to stroke, remember the acronym FAST: face drooping, arm weakness, speech difficulty, and time to call emergency services. Stroke is always a race against time, and your first nursing priority is to prepare for an immediate computed tomography scan. If the scan shows no bleeding and the patient meets criteria, tissue plasminogen activator may be administered for ischemic stroke. But if it is a hemorrhagic stroke, tissue plasminogen activator is strictly contraindicated. Instead, focus on lowering blood pressure, avoiding all anticoagulants, and preparing for possible surgical intervention. For endocrine emergencies, know how to differentiate diabetic ketoacidosis from hyperosmolar hyperglycemic syndrome. Diabetic ketoacidosis, most common in type 1 diabetes, involves metabolic acidosis, ketones, Kussmaul respirations, and moderate hyperglycemia. Hyperosmolar hyperglycemic syndrome occurs in type 2 diabetes, presents with extremely high blood glucose, absent ketones, and significant mental status changes due to dehydration and hyperosmolarity. Treatment in both begins with intravenous fluids, followed by insulin, and potassium must always be monitored. Moving into psychiatric nursing, choose therapeutic communication that is open, non-judgmental, and empathetic. Reflect feelings, use silence when needed, and avoid offering false reassurance or asking why questions. For schizophrenia, remember the distinction between positive symptoms like hallucinations and delusions, and negative symptoms such as withdrawal and flat affect. If a patient hears voices, acknowledge their experience without validating the hallucination and always assess for harm. With delusions, do not confront, instead redirect and provide structured care. Now let us talk test strategy. When in doubt, prioritize patient safety. Use the airway, breathing, and circulation method to rank responses unless safety or psychiatric issues override it. For select all that apply questions, treat each statement as a separate true or false item. Avoid choosing answers with absolute terms like always or never. They are rarely correct. And most importantly, walk into your NCLEX exam remembering this. It is not about being perfect. It is about being safe, thinking critically, and acting like a nurse. So trust your preparation, stay calm under pressure, and believe in what you have learned. You are ready. You have worked for this moment, and now it is time to show it. We're not done yet. We'll keep coming back with more must-know NCLEX content that shows up again and again on the real exam. Stay tuned. If this session helped you, do not forget to like the video, subscribe to the channel, and share it with your fellow future nurses. Be sure to check the video's description below for downloadable study guides, NCLEX, cheat sheets, and high-yield daily resources to take your prep even further. I will see you in the next lesson. Until then, stay focused, stay confident, and stay the course. You are almost there, and you are about to become a nurse.